All right. Good evening, people. This is Dr. Parijat Kumar. I'm a certified spine and sports specialist. I welcome you all to our Advanced Running Injuries Assessment and Management free live lecture by ISOMT, International Sports Orthopedic Manual Therapy. Good evening, people. This is Dr. Parijat, specialist. All right. Sorry, there was a technical glitch. So guys, I welcome you all. Please understand that this is an introductory course on the advanced running injuries and assessment. You can see the application on your Zoom link over there. Okay, so I welcome you all again. There will be a quiz after this free live lecture, and people, as we have been doing so far for the past few years, people, and actually the good news is that we have reduced the passing score, and people who would be getting 5 out of 10 in the post-lecture quiz, they all will be getting the certificates for this free live lecture. If you want the video recordings for this free live lecture, you're welcome to access our website, theisomt.com, and you can see our premium membership as well. All right. So without further ado, I will start with today's free live lecture on running injuries assessment and management. I'm Dr. Parijat Kumar. I'm a certified spine and sports specialist from the US. I will tell you a little bit about myself quickly so that you can know who I am actually, and we can start with our free live lecture. Please understand the course content or the lecture content in this is a legal copyright of the ISOMT. Please make sure it can't be shared and copied. All right. People who are new to our organization, we have a website called theisomt.com. We have a lot of lectures, courses on different areas: dry needling, pelvis, pelvic floor. We have our American experts. So if you want to learn more evidence-based and ethically from our US experts, you're welcome to go on our website, theisomt.com. All right. People who are having problems with the sounds and the video, please guys go and check your connections. All right. Thank you. All right. So a little bit quickly about myself. I was obviously born and brought up in India, and then I did my undergrad from Delhi University in physiotherapy. I'm a physiotherapist. I'm not a chiropractor or an osteopath. So I'm a physiotherapist, and I'm proud to say that. Okay. I have done my master's in exercise sports sciences from Texas Tech University. So I've done a lot of exercise physiology, from where I got my certification in registered clinical exercise specialist from American College of Sports Medicine. I was lucky enough to volunteer with Dr. Philip Sizer, great guy in the US. I really learned a lot from Dr. Philip Sizer while I was volunteering with him in a sports and an orthopedic clinic. Okay. I've also done my doctorate in physical therapy from Arizona, ATSU, Tucson. It was in Tucson. I'm a certified spinal manipulator therapist doing a lot of thrust manipulations, but I'm not a chiropractor. I'm also a certified dry needling practitioner. I have worked in the US for at least 5 years as a licensed physical therapist. I've been currently practicing in India for the last 8 years now. Actually, it's not 7 years, but it's almost 8 years now. Okay. And we started this organization called International Sports and Orthopedic Manual Therapy because we think that there's a lot of gap in what we are practicing with the patients. Because guys, before coming on to the lecture, I will tell you what the patients, I have a couple of clinics around here, Delhi and National Capital Region. Patients come to me and say that we have been doing physiotherapy with a lot of people. They are using modalities. Yes, it does help, but we are not getting the results. Okay. Whether it's a sports athlete, whether it's an orthopedic case, doesn't matter. You have to follow the evidence base. And what is evidence base? You have to follow the regional interdependence. That's what the forte of ISOMT is, regional interdependence, which means that if your athlete or your running athlete comes to you with a heel pain, okay, the problem or the root cause could not be in the heel. It could be somewhere else, maybe the hip, maybe the pelvis, maybe the thoracic spine. I will discuss and demonstrate all the things where if the certain areas are limited, your squatting mechanics can be limited. There's a lot of demonstrations and videos in this lecture today. All right. And please don't forget, there will be a post lecture quiz of 10 multiple choice question as well. And people who pass with a passing score of 5 out of 10, they will be definitely getting their certificates. Okay. So objectives of this lecture would be that we would be demonstrating you the musculoskeletal briefly, lower quarter of the pelvis, lumbar, hip, knee, and ankle. Please understand it's just a 1 hour lecture, so I can cover some of them. There will be a lot of functional tests, a quick screening that I'm sure most of you know it, but I'll quickly show them. Very simple, but the parameters have to be carefully followed. Okay. Then there are certain gait and running analysis that you can do it on a treadmill, and you can record those videos with your patients so that you can, and there are certain softwares that you can have it on the phone, which actually records these motion analysis and they play them in a slow motion where you can see the patient's proper gait and running analysis. Okay, I will be showing you some videos of the running analysis. And then you can also do some footwear and track assessment. Now, we won't be covering much of the footwear and the track assessment. Believe me, that's a different course itself. Footwear assessment, how your footwear should be in a running athlete. Okay. And then I will be also showing you some treatment techniques for the hip, ankle, and some lumbar spine. Okay. Some of the exercises and the compensatory pattern, I will demonstrate to you that how you can demonstrate between the hamstring dominance. Even you and me sitting on the chair right now, believe me, we all are hamstring dominant. Okay, our primary mover of the hip extension is gluteus maximus. You know that. Okay, so we need to assess whether the hamstring is overtaking or whether the gluteus maximus is the primary mover is working. Because if the hamstring is overtaking, then you have to work on the gluteus maximus strengthening. Okay. There are criteria like hydration and the nutrition aspects as well, which will be a little beyond this lecture. So if you have a running athlete, you can refer that athlete to a proper sports nutritionist for a proper hydration and an electrolytic balance. Okay. So please understand, guys, this is just an introductory lecture to our running injury course. We have a running injury course as well. In 1 hour, I can just cover some of it. The chat box is open. If you have any questions and concerns, you can please let me know. If you want the material and the video recording of this lecture, you're welcome to go on our website to become our premium member. And to ISOMT premium members, we can certainly share the recorded video and the lecture piece. All right. Okay, dokes. So first, quickly, I'll be talking about 10 minutes of introduction to the running. Try to understand there are various types of running. Not all the runners are the same. Okay, there could be a brisk walker, there could be a amateur runner, they are just running for their fitness. There could be a professional runner or a professional athlete. Okay, so if I'm sitting in my orthopedic and the sports clinic over here, mostly, yes, we do get amateur runners. But if you are getting professional runners or if you're working with a lot of professional runners, make sure that you follow all these criteria. Okay. There are various types of runners as well. Not necessary if there is a professional runner, whether it's a 100-meter sprint, 400-meter sprint, marathon runner, any type of runner, they can have certain movement patterns. Okay, so please identify they might be deviating from the normal, but that doesn't mean that they will have an injury or a problem. Okay, but our job is to assess a proper regional interdependence, mobility, and stability. These two things I want you all to focus on your athletes, mobility and stability. Please don't be, I was just discussing with one of our participants just before the lecture, they were all talking about the muscle. Please talk to yourself why the muscles are inhibited or hypertonic. You can be a soft tissue specialist. Yes, the soft tissue work will definitely help. We do that too. I do that too. You can do myofascial, you can do dry needling, you can do your cupping, taping, whatsoever. But please understand, you need to assess in a holistic and an evidence-based way that why that particular muscle is hypertonic. I've seen a lot of runners doing like a ITB release. Why your ITB is hypertonic? You need to know which is the primary hip abductor. So let's talk to each other. Can somebody tell me in the chat box? Can somebody tell me in the chat box which is the primary hip abductor? Tell me in the chat box. Which is the primary hip abductor? I want to talk to you guys. Which is the primary hip abductor, abductor? Tell me in the chat box. It's a simple answer, guys. It's a simple basic anatomy. I like it. Most of you are right. Vastus lateralis is not the primary hip abductor, sir. I'm sorry. It's the gluteus medius. Now you have interior, middle, and posterior gluteus medius. Which particular fibers to test and train? You need to know that in our pelvis and sacroiliac joint course. Okay. Tensor fascia lata is not the primary abductor. That's why tensor fascia lata is hypertonic. Okay. So it is the gluteus medius. Correct. All right. Good answer, guys. So you need to understand various types of athlete movements, as I said, that across the trunk, across the neck, across the shoulders, whether it's a sprint, marathon, any type of a running event, you need to know that every athlete can have a different running pattern. Not necessarily it is a faulty pattern, but you need to prevent their movement impairments. That is what the athlete movement system is, which is called movement impairment. Shirley Sarman is a reference. She has done a lot of researches on the movement impairment syndromes. You can read her book. Okay. And then you can assess the patient's malalignment, the mobility, and the stability. Okay. Identify various compensatory patterns, which could be because of the muscle weakness. But why that muscle is weak? It could be because of the arthrogenic inhibition or a reflex inhibition. Okay, so don't get focused just on the muscles and the myofascia only. You need to assess the patient's neck, thoracic spine, lumbar spine, pelvis, sacroiliac joint, hip, knee, ankle, foot. All the things you will have to cover when a running injury patient comes to you. Okay. All right. Some key points to remember, guys, consider. All right. You need to, whatever test you are doing, whatever assessment you are doing, you need to have a thorough knowledge on that. Okay. Before discussing this slide, I will quickly give you an example. All of you guys, I want you to sit up. I know some of you might be laying down. It's okay. I want you all to sit up. Okay. Sit up and let's do a quick exercise. Okay. I want you all to sit up, and I'll quickly show you a quick example of regional interdependence that I've been showing in my other trainings as well. Okay. So what the regional interdependence means, because you need your shoulders, the shoulder movement also when you're running. Okay. So the exercise is, I want you all to slouch. I want you all to slouch like this. Come on, let's do it. Guys, I want you to sit up and let's do an exercise on an experiment. I want you all to slouch like that and try lifting both the hands up. Try lifting both the hands up. I can't go beyond that. Try lifting both the hands up. Everybody, try. I want you all to sit, slouch yourself. Don't bend forward. I want you to slouch yourself and try lifting both the shoulders up. Can you go? Come on, push. Come on, guys, push. Do it. If you are doing it. All right. So you can't go up. Now try to straighten your back, perform that thoracic extension, and then do the arm elevation. How can you go up all the way? Tell me in the chat box. How can you go up all the way? While with the slouch thoracic flexion, I was not able to go up. But with the sitting straight, I was able to go up. Why? Tell me in the chat box. Tell me in the chat box. I would be very happy if you would be able to answer. And that is what they call regional interdependence. That is what is called as regional interdependence. Your small movements can be corrected just by working on a simple regional area. Center of gravity. Oh, I'm getting good mixed answers. Well, scapula does have a role to play, but why with thoracic flexion, my arm elevation was reduced. And while straightening my back, my arm elevation improved. Why? Well, again, it has nothing much to do with the muscles right now. It is to do with your thoracic spine. The moment I brought the thoracic spine in extension or straightening, my arms could go a little bit more higher. So that's why if maybe an overhead athlete comes to you with a restricted overhead movement or the shoulder elevation, you need to work on thoracic spine. That's what I've been telling. Okay. So that is the reason I'm here, that not necessary if your running athlete comes to you with a hip pain, groin pain, knee pain, heel pain, whatsoever. You need to check the patient head to toe. I repeat, you need to check the patient head to toe. Now, we don't have the time to assess and treat the person over here head to toe, but I would request when a person comes to you, yes, muscle imbalances, stability is important, but mobility of head to toe is also very, very important. So that's why I'm telling you guys to assess the patient head to toe, treat the patient head to toe, and believe me, your patients will go very happy. Okay. So some points to consider before we jump on to the functional testing, and I can try showing it by myself, or my subject over here can show. Before you do any kind of a test or examination, you need to have a detailed, confident knowledge about itself. Okay, because your patients or your athlete can sometimes judge you, because believe me, your athlete is performing that game since childhood, and they are confident about their body mechanics, they are confident about their muscles, they have coaches, they have all that training support. So whatever you're doing, you have to be best at your detailed knowledge. You need to educate your runner about what is the test going to be like and what will be the outcomes. You can demonstrate that test first. Okay. Say, for example, I will be demonstrating a simple single leg standing. So I can tell my patients, hey, this is how you have to do it. Okay. So always demonstrate, whether you're doing any kind of exercises or any kind of a test, demonstrate the person what you're going to do. Okay. If you can't demonstrate, then educate them. What is the position? What are the angles? What is the hold period? What are the results? And what are we testing with this? Okay. And believe me, your patient will really love you. Your athlete will really love you. Always compare left and right. If my runner comes to me with a right knee pain, I will definitely do it on the left side as well. And I will make notes. So if I'm doing a single leg squat or a single leg bridging, okay, in the functional assessment, then I would definitely like to make some notes that how the left single leg squat is doing, how the right single leg squat is performing. I need to make notes. Have all the equipments ready and prepared. That is a sign of a professionalism. You need to have your, maybe like a balance board, your notes, and your scenario and your area should be properly private and neat and clean. So you have to perform a proper professional assessment and the treatment. All right. Last point that I see a lot of manual therapists don't really follow is that we assess the patient, we are good at it, we treat the patient, we are fair at it, but then we let it go. Okay, I assessed you, you have this dysfunction, I treated you, now you take 2 exercises and go home, or 4 exercises or whatsoever. The problem is we don't reassess. We need to reassess the patient when we are treating it. Say, for example, if patient comes to me with a hip pain, okay, I will show you a video of my athlete over there. He was complaining of groin pain. So if I want to perform a hip manipulation, and if I find there's a pelvic upslip, okay, then I would like to manipulate my patient's hip and the pelvis. And after I manipulate, I would like to recheck. If it happened, good enough. If it didn't happen, I can perform the second time in the same treatment session again. So that's why I'm saying it is always good to reassess the patient after your treatment. Okay, whether it's a lower quarter or whether you are doing any kind of correction exercises. Okay. All right, let's move forward. So I'm going to quickly show you now the demonstration, a quick assessment of the lower quarter, which involves your hip, knee, ankle, pelvis, and lumbar spine as well. Now, I cannot, guys, understand these separate. We have different 6 to 8 hour courses on different areas. I cannot show in detail all these tests, please understand. But I generally like to start with the patient's hip according to the evidence, because if your hip rotations and extensions are limited, it will have a direct impact on the pelvis and the sacroiliac joint. If your pelvis and the sacroiliac joint is having a problem, then it will have an impact on your lumbar spine, discs, and the facet joints. Runners can come to you with a back pain as well. Okay, now you think, oh, it's a disc bulge. I don't think so, because they're constantly in a lumbar extended position. They are standing, walking, running, practicing lunging, practicing drills. Okay, I don't think so. It's a disc bulge over there unless there's an injury or a mechanism. Okay, so when I'm checking my patient's hip or my athlete's hip, I definitely like to check rotations and extensions. When I'm doing the pelvis and the sacroiliac joint, there's a test called supine to sit, where I can check whether the pelvic is in up slip, down slip, in flare, out flare, and many other. There are certain recoil spring tests, okay, that we discussed in detail in our pelvis and sacroiliac joint. Believe me, there are like 20 recoil spring tests. When it comes to the knee pain, you have to really check tibial rotation, and that is what the athlete movement system is. Believe me, what I'll tell you the reference, what I have got from this lecture, all the physios who have been in the Olympic team, whether it's the US or whether it's Chinese, okay, the material that I'm talking about today, it comes all the way from the Olympic physios. Okay, they have been volunteering in the Olympic with Chinese, with the US, and they do really focus on the athlete movement system. So when it comes to the knee pain, I will definitely like to check the patient's tibial rotation. I'll quickly show you how to do that. Now, it can be a ligamentous, meniscal, or an intra-articular overuse injuries as well. Okay, ankle foot becomes very, very important when it comes to running, because it acts as a shock absorber. Okay, your first metatarsophalangeal joint, very, very important for that push off phase. Very, very important. First metatarsophalangeal dorsiflexion is very, very important, or you can say extension. Okay, subtalar supination and pronation is equally important for the shock absorption. When it comes to lumbar spine, I'll be skipping the lumbar spine and thoracic and cervical. Obviously, I can't cover all the assessment and the treatment. So lumbar spine, you have to see the extension and the rotation coupling. In thoracic spine, again, you have to cover the extension and the rotation, including the cervical spine. Shoulder is very, very important again. We don't check shoulders, neck in our running athlete. And believe me, in my pelvis course, I have demonstrated and showed you that I can treat my patients' headaches. I repeat, I can treat my patients' suboccipital cervicogenic headaches by working on the hip rotators. I can work on my patient's neck pain by working on the cuboid bone, or vice versa. If the patient complains of the lateral foot pain in running, yes, it can be a cuboid bone, superior tibiofibular, inferior tibiofibular, pelvis, hip, lumbar spine, including C0 to C3 dysfunction as well. We have seen that by working on C0, which is the suboccipital joint, occipitoatlantal joint, and C1, C2, we have seen the foot pain to be coming down. And that is what is called regional interdependence. The pain is in the foot. The athlete can complain the pain in the foot, but I'm working on the neck and the thoracic spine and the pelvis, and the foot pain is gone. Believe me, I've treated heel pain and knee pain by not even touching the knee and the heel. I've just worked on the pelvis, spine, and the heel and the knee pain is gone. Whether it's an instability, if you talk to me about instability as well, you definitely want to work on the pelvis and the sacroiliac joint, please. Okay, I have seen, I can tell you her name is Dr. Nilsson. I've done a course from Dr. Nilsson on coccydynia, and she was the physio of the Chinese Beijing Olympic team. And I've seen that she has treated a soccer adolescent female of the knee instability, where she underwent a lot of MRIs, and the doctor said, oh, surgery has to be done. But just with one sitting of the pelvis and the pelvic floor treatment, her knee instability was 80% better. I repeat, her knee instability was 80% better. I have the video with me. I can show you, but only with one session of pelvis and the pelvic floor treatment. Okay, so that's what I'm trying to portray and tell you. The bottom line is regional interdependence. Patient will be coming to you with a heel pain, and if you're just focusing on the heel pain, passive modalities, taping, etc., laser or fancy shock wave or PRPs, I've seen a lot of doctors I've seen the IPL cricketers over here. Sometimes they say that you cannot waste an athlete's time. Time is very important for an athlete. He has to go, there's a lot of competition. Okay, so you cannot waste his time providing a passive treatment. You have to be aggressive with your athlete. You have to be aggressive with your patients in bringing the results, maybe in 1 sitting, 2 sitting, or maximum 3 sitting. Okay, you should at least give 50s to 60% results to your patient in the first 3 sittings, please. Okay, shoulder screening is important for your running as well, believe me. All right, now there are certain quick functional tests that I would like to show you. Okay, there are many functional tests. All right, very simple and very self-explanatory, but you need to know what kind of a parameters to follow. Okay, now this is called simple a single leg standing. Okay, I can demonstrate that by myself. Okay, so very simple, if you can see in the picture. Okay, so what you're doing is with a cross arm, you're asking the patient to just stand on one leg. Okay, let me kind of show you myself. All right, simple. So I can show you over here. Okay, so I can hug myself. Okay, wait, let me just let me show you this. Just pardon my backgrounds, guys. So I'm standing over here. Okay, I can hug myself and stand on one leg. Now, the moment I stand on one leg, I kind of shift my weight. You need to see the pelvic drop. So if I go like this, okay, this, see my pelvic drop. Okay, so I need to hug, and if the patient goes like this, that's a pelvic drop. This, pelvic height, pelvic drop, pelvic height. You need to see the stance leg hip rotations. You need to see the stance leg tibial tuberosity. Okay, you need to see whether the tibial tuberosity is facing medially, tibial tuberosity facing medially or laterally. Okay, so if I'm standing on one leg, okay, make sure that my knee is not going medially like that. Okay, males or females, they can have a problem with the tibial tuberosity as well. Okay, because they can have more medial femoral anteversion, and their tibial tuberosity can go medially. I will talk to you about that. Okay, when you're doing a single leg standing, I can share the presentation. These are the parameters that you have to look, that you have to at least ask your patients to hold there for at least 30 to 45 seconds. And if your athlete obviously is young, doesn't matter the age, because people who are in an athletic scenario, their balance is quite good. So the normal duration of a single leg balance should be around 30 to 45 seconds. You see how many touchdowns they're doing, their trunk is leaning to one side, or their hip is going into internal rotation, supination, pronation, or they are losing their balance. Okay, so the quality of these tests that you have to really observe, and this observation comes with experience. The patient can be an ankle sprain, as simple as that. Okay, tell them to stand on one leg in your rehabilitation part and see. Believe me, their proprioception will be definitely affected, and they will not be able to hold for 30 seconds. Okay, you can challenge it to eyes closed or eyes open. Okay, eyes open first and then eyes closed. And you can use the same thing for your corrective rehabilitation exercise as well. Okay, the next test is single leg sit to stand. As I said, there are a lot of functional tests, guys, but these are quick screening tests that you can do. I see a question. You can ask question in the chat box. I will try to answer to my best capacity. Do we give them 1 or 2 practice tests before assessment? You can, that's a good question. I can show that to my patient. As I said, whenever you are doing, if I go back, if you see the slide, points to remember, always demonstrate to your patient or your athlete first. I told them, sir or ma'am, what you're going to do is you're going to hug yourself, because that actually compromises your somatosensory movements as well when you hug yourself, and stand on one leg. Okay, that's how you are supposed to do, at least for 10 to 30 seconds. Initially, I give them a leverage of 10 seconds, and then you can hold it for 30 seconds. And I observe their standing posture. Okay, and they can focus on a point if you want. They can focus on a point for their eyes and their proper oculopelvic reflexes. Okay, because if they're distracted, or if their eyes are moving here and there, believe me, they will lose their balance. So it is good to ask them to focus on a point and then do a single leg standing. All right. Next is sit to stand, single leg sit to stand. Now, obviously, the primary hip extensor is your gluteus maximus. It is testing your quads, your glutes, and your hamstring. Arm cross, very simple. Now, there are certain modification of this. How many times to do? What is the parameter? So you can ask the athlete to do this 5 repetitions slowly, initially, okay? And then you can ask them, and you can increase the challenge. You can tell them to quickly do these 5 repetitions, quickly, maybe in a matter of 3 to 5 seconds, okay? And then you can challenge it further and say that, let's see how many repetitions you can do it in 30 seconds. These are the modifications of single leg sit to stand, okay? And you can vary the height of the bed or the chair wherever you are, because the lower the chair, the difficult it is, higher the seat height, the easier it is, okay? I will show the manual assessment demonstration and the treatment part as well. So how you do it is, I will try to demonstrate on myself if you want, okay? So how you can do that is, so let me kind of stop sharing the screen. I will try my best. I'm not an athlete over here. So if you can see, so I will put my hand on the pelvis, okay? I'm taking my one leg down, up like that, making sure I don't fall, okay? And look at my stance phase. Now, I might be having a faulty pattern. My knee can go in, my tibial tuberosities can go in. So I tell my patients to maintain the tibial tuberosity in the line of second and third toe. I repeat, I tell my athlete to maintain the tibial tuberosity in the line of second to third toe. If it is going medial to that, definitely you need to work on the pelvis and the hip rotators. Okay, I see a question over there. That's correct. Knee will move medial, and that's a faulty pattern. That's what I'm trying to explain. That's a faulty pattern. You need to see the tibial tuberosity moving medial to the second toe or the medial border of the foot. Okay, that's what the marker and the reference point is. So how you perform is, I can take my one leg up. 1, 2, 3, 4, 5. Now the seat height is quite high. I can challenge myself to reduce the seat height. I'm trying, this is a hydraulic bench. I can reduce the seat height. And now I can perform the same thing. I've increased the challenge, okay? Making sure that I don't have a knee pain tomorrow, okay? Kiss and come back. See, I lost my balance. So I need some training there, okay? Let me try with my right leg. I sit and come up. Now see, my pelvis is dropping. So I need to work on my pelvic abductors as well. Come up. Come up. I lost my balance. So yes, that's how you see your patient's different faulty patterns. So if I'm losing my balance, I definitely need to work on my core and my hip abductors. Because when you do a single leg standing, it is basically your extensors and your hip abductors, which is stabilizing your pelvis and the hip. All right. I will come on to the patellar malfunction. That is a very good question. If a patient complains of the anterior knee pain, you don't want to perform a single leg squat. You can simply start with a proper squat, a simple squat, okay? A simple squat, a simple squat. You need to see the modification, a simple squat. My knee should not be going over the toes. My knee should not be going over the toes. Because if it does, you're stressing the ACL. If your knee goes beyond the toes, you're stressing the ACL. So make sure the mechanics are right, okay? So if your patient is complaining of patellofemoral pain, obviously the patient will complain of anterior knee pain, okay? And they can complain of squatting. So before you do a single leg squat or a single leg sit to stand, please perform the squatting, okay? Patellofemoral tracking problem is patellar malfunction. All right, well, medial joint knee pain can be because of many reasons. All right. So I told you the parameters. You can ask the patient to do 5 repetitions first, slowly. and then do the 5 repetitions quickly. That tells me the power, okay? And power is required for an athlete for running, whether it's a short distance or a long distance. Power is very, very necessary. That's why I tell my athlete to do 5 repetitions in like around 3 seconds, okay? And then how many repetitions can you do in 30 seconds? Okay, you can do maybe like 20, 25 with a proper mechanics. If you're losing your balance, the game is over, okay? So that will tell me the endurance and the power of my quads, hams, and glutes, okay? I will show you how to differentiate between the glutes and the hamstring dominance, because I told you that most of us are hamstring dominants, okay? So that's how I will show you how to differentiate between the hamstring and the glutes, okay? Lateral step downs, okay? Very important test and screening that you can do in your running athlete as well and in your normal population as well, okay? So very simple. As you see in the picture, I'm just asking my athlete to step down laterally, okay? To step down laterally. I'm seeing for the horizontal pelvic plane, okay? I'm looking for the horizontal pelvic plane. I'm also looking for the patient's knee, ankle and foot, and the lateral trunk lean, okay? I'm looking for all these structures. And if you see carefully, so I can show you myself, and I'm not the best at it. So I can go up, and I need to maintain a proper horizontal pelvic plane. Okay, it should not drop like this. Patient should not be doing this. This is called pelvic drop. No, you need to maintain the horizontal pelvic and just kiss the ground with your toes. That's it. Kiss the ground with your toes. Now, what I'm doing is I'm putting my weight on the left side, if you see. So I'm compensating. I'm not doing it at the best. I'm compensating. I'm putting all my weight on the left. Okay. So if you see carefully, and my knee can go medially. Okay. So let me show you again. Lateral step ups. Please make sure that the stance phase, you have to always compare on both the sides. Okay. I will tell you how to check the hamstring strength and the gluteus maximus differentiation. All right. So as I told you that you have to see the arms. If I lose the arms, if I try to catch myself, the game is over. If the trunk is leaning to one side or the other, the game is over. The pelvic drops, test is over. Knee position, knee tibial tuberosity going medially, that's a faulty pattern. The steady stance, if the patient is wavering on his foot, or the foot is wobbly, or the patient is kind of catching the balance like I was catching my balance, the test is over. And on all these criteria, you can have certain score, okay? As I said, knee position. Now your knee tuberosity, if it is going medial to the second toe, that can be scored as 1. If it is going more medial, beyond the medial border of the foot, that can be scored 2. Okay, so there's a proper charting and the scoring for this proper lateral step down test. Okay. Knee to wall test. This is generally done to assess the ankle dorsiflexion range of motion. Okay. I have a question. Absolutely. Tibialis posterior dysfunction can affect the hip stability. Absolutely. Because a person like me who is a flat foot, I'm a flat foot person, tibialis posterior is the weakest muscle, and you need to know how to train tibialis posterior. We are having our hip, knee, and ankle hands-on training in Delhi and Mumbai very soon. We will be teaching all these exercises and the trainings, how to train tibialis posterior, how to check the ankle alignment and all that stuff. Okay. I will tell you in my hands-on training, guys, about the flat foot athletes as well. I myself is a flat foot, what muscles to work on, how to work on the tibialis posterior, how to strengthen that, and what other pelvic areas to work on. Okay. So talking about knee to wall test, this is a test used for ankle dorsiflexion. Now, I don't need to demonstrate that to you. It is a pretty self-explanatory. If you see in the picture, the first picture, this person tries to take the knee and touch it on a surface. Now you can do it against a wall as well, okay, and perform an ankle dorsiflexion. What you're supposed to do in this test is you need to see the distance between the toe and the wall or the table in this case, okay. So this person is doing it against a table, okay, the knee is touching the table, and we are measuring the distance between the great toe and the table without the heel being lifted. Now, if you see the second picture, her knee starts lifting over there. So I tell the patient to stop, okay, because I ask the patient to go back forward and then try to touch the knee to the table. And then in that case, her heel started lifting, and I said, please stop. So heel should not lift, and that will show me a proper ankle dorsiflexion range, okay. And the research, if I talk about the researches, there are researches by Green et al., which says that the limited ankle dorsiflexion range does not actually contribute to your calf injuries. This test has shown a good intra and the inter-rater reliability. It is quite simple to do it, okay. There are certain researchers which say that increased ankle dorsiflexion can actually lead to increased genu valgum. I repeat, limited dorsiflexion can lead to increased genu valgum. Okay, so if you think your patient's knee is going medially and you think it is coming from the hip, most of the time we think like that. I'm sorry, it is actually the ankle which is causing the genu valgum. Okay, and increased ankle dorsiflexion, sometimes people who are very flexible, in case of females or males, they can have increased knee flexion angle, and that can reduce the ground reaction force. Okay, so please make sure to check for the ankle passive mobility as well, and this functional stability as well, functional screening as well. Somebody's asking me about the distance. Well, it depends upon patient and the athlete to athlete. In males and females, it is quite different. And the age also matters. The age, the gender of the athlete, they all have different parameters as how much is the average distance. I hope that's clear. Well, I don't want to do this test in standing because there are a lot of compensation and anti-gravity compensations that you can do. Well, if you're having genu valgum since birth, then that is a structural defect rather than a functional defect. Okay, not necessary. If you say that if it's somebody's having a structural genu valgum, they will have limited dorsiflexion. Not necessary, because that is a structural one. But you can always check, and we can always do a research on that, experimental research. All right. I will come on to the demonstration of the manual therapy assessment and the treatment right now. Next functional quick test is calf raise to fatigue. See carefully. When we are doing the calf stretches or some calf raises, we actually do it wrong. Why? Because you have to ask your athlete to completely go down in 1 second and completely come up in 1 second. You can do it with the other leg supported or the other leg unsupported as well. Okay, because what most of the time people are hopping, they're just jumping on their calf and they think they're stretching their calf and they're doing the calf pumps. No, it's not the calf strengthening. That's not a proper calf strengthening, because if you're bouncing and if you're just doing a time pass over there, believe me, the test is over. Okay, or if in this case the runner is fatiguing or the athlete is fatiguing while doing this, you can stop. Okay, there are certain chart values for the normal, if you ask me, for males and females, as I said. So if my athlete is between 20 to 40 years of age, the normal for males are 30 to 35 repetitions. For females are 25 to 30 repetitions. For an athlete of 20 to 40 years of age, I'm talking about the number of repetition. So my female athlete, who is a 25 or a 30-year-old female, I can expect around 25 to 30, which is the normal calf raises. Okay, in a male it can be 30 plus to 40. Okay, how you do it, I can simply quickly tell you. Believe me, I might lose my balance and the test is over. Okay, so I have a step over there. So if you see, So what I'm doing is, let me kind of stop this. You can ask the patient to take a support as well, 2-finger support in front if you want, okay? But I'm just showing you with an unsupported one. So my one leg is supporting, knee bend, and my other leg is, if I can take this up a little bit, okay? I completely go down with my right foot with a dorsiflexion and completely come up. I completely go down and I completely come up. I completely go down, I completely come up. Now I can take a support as well, okay, on the foot with somebody, and what I can do is I can take my foot off, okay. I can completely go down, completely come up, completely go down and completely come up, go down and come up. So if I'm not completely going down and coming up, or if I'm losing my balance, the test is over. I will show you the test again. Here it is. There should not be any hold period, because this itself is very difficult, please. Going up completely down and completely coming down in 1 second, there is no hold period, okay? If the runner is fatiguing, the test is over. Believe me, doing 2 times with unsupported was very difficult for me itself. So this is not an easy test. All right. Now, as I said, there could be a lot of other functional tests as well for the runners. I will come on to the manual therapy assessment. Yes, it can be tested barefoot, correct. So you can check for the strength and the stability, okay? You can ask the patient to perform a squatting with arms elevated, okay? Now, I have a question for you guys, okay? Squatting, if I'm doing with arms elevated, okay? So I'm doing an arm elevation, okay? What I can do is I can stand on this if you want, okay? I'm doing an arm elevation and doing a squat. Then I can do a hug and then squat. Arm elevation. So tell me, guys, I have a quick question for you, okay? So if the patient is making an arm elevation and is not able to squat, but is able to squat with arm crossed, what does it tell me? Tell me in the chat box. That's a little difficult question for you. And that is why regional interdependence is very, very important. My question is, if an athlete cannot properly squat with arms elevated, but can do a proper squat with arms crossed, what does it tell me? Tell me in the chat box. Now, that's not an easy question. I'm getting some good answers. Absolutely, it is the spinal mobility. Absolutely, it is a thoracic spine mobility. It's a thoracic spine which is restricting when you're putting the arm elevation into squat. So that's why I told you, you have to work on your patient's neck, thoracic spine, shoulders, no matter what the injury is in the lower quarter. And that's what we will be training in our upcoming hands-on training very soon in Delhi and Mumbai, okay, in the October. All right. You can do a single leg bridging, you can do reverse lunges, you can do planks, which can be side planks with the adductor lifts. You can do forward planks, you can do a single leg bridging, you can do slump tests. So there are a lot of functional tests that you can perform with your patients, okay? And they can be modified and challenged according to the patient's performance or athletic levels, okay? All right. Now, gait analysis, I have a little bit of a gait analysis over here on one of the subjects that we had. So this is a video, okay? Sometimes you can ask the patient the video from their running track as well. I will show you a video from one of my patients who was having a groin pain. All the ultrasounds were clear. There was no problem with the rectocele or any kind of a urocele. There can be pubic symphysis dysfunction as well. It'll be difficult for me to demonstrate to you assessment and treatment of pubic symphysis, but when you're doing a proper video analysis of your patient, whether it's a treadmill analysis or a track analysis, request them to shoot two videos, which can be from the side view, sagittal view, or from the front or the back. I prefer back view or the posterior view better. Okay, you can do it at an inclined level, in a gradually increasing from 1 to 10 with a speed of 4 kilometers to 10 kilometers. Okay, and you can increase the speed to 0.5 in every 1 minute. And I will be seeing my patients all head to toe. Now, this is a video. If you see, as you can see the video running over there, this lady is running on a treadmill with a speed of 6 miles per hour. I'm sorry. It's a video from the US. We have miles per hour over there. So she was running on the 6 miles per hour. I will play this video again from the sagittal view. So I think her heel strike is quite good over there. Okay. Now she seems a little bit of unstable on the knees, especially on the right knee. I want to see her hip extension as well. Okay. She is lacking a lot of hip extension, and hip extension is very, very important for your running. If you see her hip extension on, basically, this is a video from the right side. So her hip extension is quite limited over there, which I will definitely like to work on. Okay. So that's how you have to see the video. There's another video of the same person from a posterior view. If you see, now here from a posterior view, I'm looking for her pelvic drops. I'm looking for her neck. I'm looking for her thoracic spine, lumbar spine, knee, foot, subtalar, eversion, inversion, supination, pronation. Okay. I'm looking at all these aspects from a posterior aspect over here. And her arms swing as well. And as I said, she is lacking in hip extension for sure. This is another individual with a sagittal view. I have a couple of them. Now he's doing a kind of a brisk run. He's doing it at 4.5 miles per hour. Okay. His upper trunk is quite stable. Okay. Again, this person had a right knee pain with the running. Okay. And if you see carefully, his right hip, I can just make it out from the side view. His right hip is more internally rotated. You need to see the toe out and the toe in as well. Please see the toe in and toe out. His right hip is internally rotated. Patients can compensate by externally rotating that. I will show you how to do a spring test. This is another individual, if you see carefully on our treadmill analysis. Now he is on 4, he was on around 4 or 4.5 miles. This is a posterior view, if you see. Now, if you see carefully, guys, can somebody tell me exactly? His trunk mobility is quite limited. If you see, he has a little bit of a lean onto the right side. See the lumbar and the iliac crust creases as well. See the lumbar and the iliac crust creases. He's definitely bending onto his right side more when he's running. So he's stressing his right leg. See his right waist angle. He has a right trunk lean while running, which can be a faulty pattern. The same individual from the side, if you see. Now, in the sagittal view, I think he's overstriding. Overstriding means that if you take the heel and the foot beyond your hips, I repeat, if you overstride, or if you take the heel or the foot over beyond your hips forward, then you might be predisposed to cause injuries in your hamstring, or you might be overstressing your body, and there would be a lot of energy expenditures. So we say that if you are doing a brisk run, or maybe a speed of 4 to 6 miles per hour, your heel strike or your toe strike should be at the line of your hip. I repeat, your heel strike or your toe strike should be in the line of your hip, so that you're not spending too much energy, you're not injuring your hamstrings, and you're not overstressing your body. All right. This is a video of one of my sprinter. He was a 400-meter sprinter. He's actually performing a 100-meter over here. He sent me his video from a stadium. We have a famous stadium over here in Delhi. Now this patient had a groin pain. Now I don't want to tell you before the video what problem he had. Now see his video. It's a little bit of a disturb with the other people in between. So that was a quick, see that again. He came to me with a left groin pain more than the right. See the video again. Now you have softwares that you can put these videos in those mobile softwares and play it in a slow motion. There are certain softwares in the phone. Those are called sports motion analysis. I worked for a few months, I'll be honest. I worked with in few months in the University of Miami in a sports motion analysis laboratory. And I see it's quite high tech. They have cameras and all. So they will tell you with the plantar sensors and all that what is the problem and where the plantar supports are. Even your plantar supports can vary. There are researchers that if I pop my patient's pelvis and sacroiliac joint, the pressure on the plantar aspects can vary. Yes, he was having a hip dysfunction. He was having a pubic symphysis dysfunction. He was having a pelvis dysfunction. So you have to check that athlete from head to toe. Okay, I will play the video again. I remember his major complaint was left groin pain. Again, he had an increased left hip internal rotation. That was because of the pubic symphysis. And he had a little bit of a snapping as well. Your runners can sometimes have snapping syndromes as well. Clicking sounds around the pelvis. All right. I will quickly demonstrate some manual therapy assessment and the treatment. Okay. But when it comes to the management of the runners, this is the last part, guys. You can do certain soft tissue mobilization. Not that I'm saying that the releases or the myofascia or the dry needling or the cupping that you're doing that will not help. They will definitely help. But you need to understand what is the root cause of the patient's hypertonicity or muscular imbalances. Okay. I told you there could be a thoracic spine stiffness just for the calf tightness. There could be a neuromeningeal tightness. Your slump test can turn out to be positive. There could be a erector spinae tightness because of the pelvic dysfunction, and the athlete can have a low back pain. Okay, we do a lot of thrust manipulation in ISOMT. We teach all these thrust manipulation, muscle energy techniques, soft tissue, dry needling. Acupuncture does help. It is based on different energy meridian system. What exercises to give, how to check the gluteus maximus and hamstring, what are the compensatory patterns, what is the movement impairment patterns you have to see. And then if I think that this person might need a footwear change or a referral to an orthotist or a podiatrist, podiatrists are generally the foot doctors in the US, okay? Because I've seen their back pain, the knee pain going in like 2 minutes the moment they change their footwear, or the moment you give a small modification in their footwear, the pain is gone. Knee pain, hip pain, groin pain, whatsoever. Runners generally have a lot of groin pain, and Dr. Ufuk, who is our sports physician in our team, he just recently concluded a free live lecture on the groin pain in the athletes. You can go and see that on our YouTube or on our website. Okay. Shoe and sole recommendation, again, itself is a different course. What kind of a shoe, what kind of a sole you need to recommend, what kind of a brand you recommend. I will not recommend or name any brand right now, but whatever sole, whatever foot improper dysfunctions that you find, you can recommend those type of footwears to your patients. Okay. Diet and hydration along with the electrolytic imbalance is very, very important. If your patients are not properly hydrated or not proper electrolytic imbalances there, believe me, they will be predisposed to injuries, no matter how good manual therapist you are. So hydration and electrolytic balance is equally important. Sometimes psychosocial counseling is also very, very important for these athletes, because if they are not performing well, if they are not able to participate and get accepted in their running competition, they're not going to win, they can go into certain depression. Okay, I'm going to tell you about the glutes and the hamstring. All right, so now I'm going to quickly show you the demonstration of certain manual therapy assessment of the pelvis, of the knee, tibial torsions, and the foot. And then I will show you certain manipulation techniques along with the muscle imbalance of glutes and hamstring. And that will be all for today. Okay. So just bear with me. All right. So I have a subject with me. Please can you be on your back one? Yes, sir. Yes, sir. So my patient or the subject lays down supine, okay, over here, if you see. So I'm going to demonstrate a quick test for you, which is called supine to sit test for the pelvis. Okay, I need to check this person's pelvis alignment. I can start from the hip, as I said, or I need to check her hip rotations. Many times people like to, again, guys, listen to me very carefully. I have seen a lot of manual therapists checking the hip rotations with a knee bent position. That's fine. You can do that. But I like to check my patients or athletes' hip rotation in a complete knee extended position, because that's what is guaranteed or warranted when you are walking. Your knee is extended when you're walking. So that's why I like to check the patient's hip rotations in knee extended. Okay, I will demonstrate that. So how you can do that is, you can, so I'm starting with a hip rotation. Okay, so first what I like to do is, I like to tell my patient or athlete to just relax. Okay, I'm looking at the patient's rotation of the hip. I'm looking at the toes where they are pointing. If you see carefully, now see the angle of the toes. I think she's quite symmetrical over there. Okay, so her toes are pointing, because many times if you see, one of the toes might be a little bit more externally rotated. That tells me that the hip external rotators can be tight and the internal rotation can be restricted. Okay, so some patients can be like that, but she's like that. Okay, or some patients can be like this. They might be into internal rotation, but most of them are into external rotation like that. Okay, so how I like to check is, I can show you on this leg, which is closer to the camera. I like to take, this is called a spring recoil test, by the way, for the hip internal rotation. I like to hold my hand on one proximal to the knee on the thigh and the other hand on the shin bone. Okay, what I'm doing is I'm going to perform a hip internal rotation. This is called a recoil spring test. Okay, so please relax, ma'am, if you can see. So look at the toe. Look at the toe. I don't want to block the view. So I'm checking for her hip internal rotator. And then I can give a little bit of a spring and feel for the recoil. That's simple way to check for the hip internal rotation. I can show you from the other side. Hip internal rotation. She's at the end range over here, and then providing a little thrust, kind of a springing onto the hip internal rotation over there, and I feel for the recoil. I feel for the recoil. So I start with a hip internal rotation first. Many people like to do hip internal, external rotation, internal rotation like that as well. You can do that. Not I'm saying that is incorrect. I like to do it in a knee extended position. All right. Many people like to do it in a prone position as well. So please can you turn on this? So many people like to check the hip internal rotation, all right, or external rotation. Well, external rotation is generally not restricted, but internal rotation. Okay. Now in this same position, I can check for tibial torsions. And how I like to do that is, I would like to visualize her foot or feet from the top, and I externally rotate her tibial into external rotation. I repeat, I'm rotating her tibia into external rotation and now into internal rotation. External rotation, internal rotation. And I feel that her left side is a little bit restricted onto the tibial internal rotation. Okay, I can show you from one side. So tibial external rotation, tibial internal rotation, tibial external rotation, tibial internal rotation. That is a lot of movement impairments you can find when it comes to the knee. When it comes to the knee, there are a lot of movement impairments on the tibial torsions. So that's how I check for tibial torsion in the knee. Okay. Now coming on to the glutes and the hamstring dominance that most of you were interested in. It's a simple way to check. Okay. But a very fine way how you can check that. Okay. So what I'm going to do is over here. And please make sure that you perform a proper test. Okay. So I'm going to perform the glutes and the hamstring differentiation on her right leg. Okay. I will tell my patient or an athlete to completely bend the knee. Completely bend the knee without lifting the pelvis over here. Why? Because it rules out the hamstring. So I've completely bent the knee. Okay. Now what I'm going to do is I'm going to put my one hand over here. I'm going to feel for her hamstring. I'm maintaining that knee flexion, because what the patient does is when they will perform a knee hip extension, they will start straightening their knee. So that's why I like to put my hand over there. I'm palpating her hamstring, and is it okay if I palpate your glutes, ma'am? Always take the permission of your athlete or your patient before you do whatever you're doing. Okay. So I'm going to put my one hand on her gluteus maximus. Okay. So what I'm doing right now is differentiating between the hamstring dominance, which we all are, and the G max as a primary hip extensor. Okay. So I've completely bent her knee. I'm palpating with a gentle pressure her hamstring muscle and her glute muscles. Please take the permission of your subject before you do that. Okay. So what I want her to do is I'm feeling for the contraction. Which muscle contracts first? I repeat, which muscle contracts first when she performs a hip extension? Okay. Complete knee flexion, palpate the hamstring, palpate the G max. Can you slowly lift your knee, hip into extension? Please relax, ma'am. Easy, easy. Gently do it. Definitely, she is recruiting her hamstring before the G max. I repeat, she's recruiting her hamstring before the G max. That tells me that she is also a hamstring dominant person. I will repeat this test. Go slow, man. So I palpate the hamstring. I palpate the G max. When she performs a hip extension, I will be feeling that which muscle fires the first. The primary pattern should be that your G max should be firing first. But in 99% of the cases, the hamstring is firing. So can you lift your leg up, ma'am? Now, if you can see, it is quite visible as well. Can you lift up? See, she's recruiting the hamstring first before the G max. So that's how you differentiate between G max and hamstring dominance. And believe me, 99% of your runners would be hamstring dominant. How you treat that is you will have to really learn that in our hip, knee, and ankle course, which will be in our hands-on training very soon in Delhi and Mumbai. Okay, you can give some hip manipulations for that as well. Okay, next I would like to show you supine to sit test that you can perform for your pelvic up slip, down slip. All right. Well, there is a debate when somebody is saying that open chain. Well, a runner is not running in an open chain. I can believe that in an open chain, your hamstring can be dominant for knee flexion or hip extension. But when a running injury or a running athlete comes to you, they are running and we are walking in a closed chain pattern. We are not in an open chain pattern. So the primary mover should be the G max. But I don't disagree with you. Okay. So please continue on your back, ma'am. I'm going to demonstrate a quick supine to sit test of the way you can check for the patient's pelvic obliquity. Okay. Can you perform a bridge, ma'am? If the patient can perform, that helps to square the pelvis. Please relax. Please relax. If the patient is not able to do that, I can simply go back, perform a little bit of a sway to square her pelvis. Now I'm going to see her medial malleoli or the heel. Okay. And I think her left side is a little bit longer. This side is a little bit longer. Okay. Now, this is not a true leg discrepancy. You can differentiate between the true leg discrepancy and a functional leg discrepancy as well. Okay. So right now, her left leg seems a little bit longer. Okay. Can you breathe out and sit up, ma'am? All right. As usual, Her left leg becomes longer. Her left leg becomes longer. That tells me that she definitely has a pelvic obliquity on the left side. So she can be sitting in an out flare or she can be sitting in a down slip as well. Now, right now, the lecture is a little bit beyond of the scope of me explaining what is out flare and down slip, but that's how I check the pelvic obliquity. And I will definitely treat her for out flare on the left side because her left side was going long to long. I can manipulate her. How to manipulate for that, I will show you right now. So there are two techniques I can show you for the hip, ankle, and the out flare that can work on your pelvis and the sacroiliac joint as well. Okay. So if a patient comes to me with an ITB hypertonicity, I will definitely like to work on my patient's hip joint. A simple thrust manipulation of hip joint, hip into a relaxed position, flexion, abduction, external rotation, holding onto the distal tibia, not the ankle, but distal tibia right over there. I lean back, and perform a thrust. She was resisting it. I can feel that. Please relax, man. Please relax. Okay, please relax your leg. I lean back. I can show you a little bit from the far away. Okay, please relax, man. Please relax. I can hold it. Don't worry. Flexion, abduction, external rotation. I lean back. That was the ankle. So sometimes you kind of pop the ankle as well, but make sure you're holding the tibia from the distal aspect. Okay. So that was a quick hip manipulation for runners, which is very, very handy because when they're running, or even your basketball players, tennis player, whatsoever, they're having a lot of hip shock absorption. Okay, a lot of shear forces are coming on the hip that is impacting onto that socket joint. You're jumping, you're running, so that is impacting onto the hip socket. Okay, so that's why you need to kind of work on the hip first before you work on the pelvis and the other areas. Okay, the next technique I can show you on the ankle. Now, say for example, if the patient's first MTP is limited, can you straighten your leg, ma'am? Okay, I will simply check for her first MTP extension or dorsiflexion. Her left seems a little bit restricted. I will definitely like to mobilize her proximal phalanx on the tarsal head dorsally. Okay, if you remember the convex concave rule, I will mobilize the proximal phalanx on this foot dorsally if her first MTP dorsiflexion is limited, metatarsophalangeal joint. First MTP was limited, she will not have a proper push off while running. Okay, we can perform a simple ankle dorsiflexion. So can you take your ankles into dorsiflexion, ma'am? All right. I think again her left side can be restricted. We can try manipulating if I think her left side ankle or the talocrural is restricted. You can perform a posterior glide. Please relax, please relax. You can perform a posterior glide to check for dorsiflexion. You can perform an interior glide to check for plantar flexion. And we will discuss that in detail very soon, hands-on. All right. So if I think her left ankle dorsiflexion is restricted, excuse me, I can provide a posterior glide or a posterior thrust, or I can provide a talocrural distraction manipulation as well. Please relax. Talocrural distraction manipulation as well. I've already done that. So that's how you perform the talocrural distraction. Dorsiflexion, eversion, and boom. All right. So you can perform it on the right side. Okay. Ankle dorsiflexion, eversion. Please relax, please relax. There we go. Okay. You will hear a crisp pop sound when you perform these manipulations. All right. We do a lot of dry needling as well. If you think the calf is sore or calf has some trigger points, especially the lateral gastrocnemius or the biceps femoris, lateral hamstring, you can perform some dry needling that we'll be teaching very soon in person. All right. Next and the last manipulation that I would like to show is she was sitting in a left pelvic out flare. Her left supine to sit was long to long. So she's sitting in a left pelvic out flare. I would like to manipulate her left pelvis for an out flare. So please can you turn that side now? So the patient is in a sideline position. Okay. Her left side was sitting in an out flare. So I'm going to manipulate her left pelvis over there. Okay. So she can bend the upper leg. She can straighten the lower leg. Okay. She's going to hold with one hand to the bed, and she can give one hand to me where I can stabilize it. Okay. I can show you from this side if you want. So if you see carefully, I will show you the position. See my position and the patient position. So the patient's upper leg is bent. I'm going to work on her this pelvic out flare. She's going to hold my hand like that. I'm going to place my hand on the pelvis. I'm going to place my hand on the pelvis. Let me show you from the side a little bit. There we go. So please can you hold on to my wrist, ma'am? So she's holding onto the bed, stabilizing that. I'm stabilizing her hand and the trunk. My one hand comes onto her PSIS. Okay. Now she was sitting in a pelvic out flare. I'm going to correct that. Okay. So please relax, ma'am. Please relax. Make sure I'm not twisting her too much and popping her lumbar spine. Okay. So please take a deep breath, ma'am. Breathe out. Deep breath. All right. That was a crisp pop sound over there. Okay. So that's how you fix the left pelvic out flare. And that was a thrust. I gave a quick thrust. All right. So those were some of the few techniques, guys, I could only cover in my assessment and the treatment part. After I done that, as I told you, I will recheck it. Whether it is a sports athlete or whether it's an orthopedic case, you want to do a manual therapy in a proper regional interdependent way. Whether she was a heel pain patient, she had a lateral foot pain, I will definitely like to check her pelvis, her sacrum, her hip, her knee, her lumbar spine, including the thoracic spine as well. Okay. I'll share the presentation. We are almost getting over. Sorry for going over time a little bit. Now, if you want to perform some other soft tissue like dry needling, which we are teaching very soon, after this, I would definitely like to tell her certain pelvic strengthening exercises so that she can maintain that out flare, or I can give her some home exercise program, some mobility, some self-mobilization to prevent that out flare as well. Okay. So that's all for today, guys. Thank you so much for your patience. We have a quiz after this lecture. So people who pass the post-lecture quiz with a score of 5 out of 10, they will definitely get the certificates for this free live lecture. And one quick announcement I would like to make is we are coming. I'll answer your question. I'll come to that question. That's a great question. We are having a hands-on training very soon in Mumbai and Delhi. Okay, we will be coming to Delhi, Mumbai from October 1st to October 8th. You are welcome to do a certified spinal manipulative therapist course covering your pelvis, sacroiliac joint, and lumbar spine in elaborate detail, covering all the assessment, palpation, treatment, assessment, muscle energy technique, thrust techniques, manipulation techniques, all that. We will be also doing extremity manipulative therapist covering your hip, knee, and ankle foot. We'll be doing dry needling, US-based dry needling as well, covered by myself, Dr. Rianne Mendes. She's a certified dry needling practitioner. Dr. Ratan would be there in Mumbai as well. We all would be there in this hands-on training who will be helping you all. It's not just me, but there will be a lot of other experts who will be guiding and training you in person in Mumbai and in Delhi in these 3 days, 5 days, or whatever you want to register for, you can register. Okay. Somebody was asking me about the pelvic bridging. That's a great question, guys. That's a great question. Somebody was asking me about how you can recruit Gmax in a pelvic bridge because hamstring takes over. Absolutely wonderful question. You are absolutely right. In a pelvic bridge, when you do, your hamstring takes over. Most of the time, patients are performing the pelvic bridge on their toes. Either they are using their calf muscles or they're using their hamstring muscle. A very simple, quick prescription that I would like to tell you is please turn on your back, ma'am. Spine. So if you want to perform a pelvic bridge where you really want to target your Gmax, a very simple way that you can do what I did in checking the hamstring dominant is completely bend the knee. Completely bend the knee. Completely bend the knee. Perform a posterior pelvic tilt and ask the patient to perform a pelvic bridge. That's it. So if you see, I have asked the patient to completely flex the knee. Please relax. If the patient is performing a bridging like that, please perform a bridge. You are absolutely right. It is a hamstring dominance again. They are using the hamstring. No, that's a wrong way of bridging. Okay. So a correct way of bridging is completely flex the knee, perform a posterior pelvic tilt, and then perform the bridge. That will recruit your Gmax. You can try it yourself doing it. Okay. So we have a lot of these exercises, treatment techniques in the hands-on training that I'm talking about. Okay. Do we have any more questions? I can wait here for 5 minutes if you have any more questions. Please stay tuned for the pelvis course quiz. I can share if you want in the chat box here itself. So there's a quiz link, people who want the certificates for this lecture. There's a passing score of 5 out of 10. Okay. So you can go on this link and perform the quiz. All right. It can be shared on the WhatsApp group as well. We have already shared that. I will share that again. And I would definitely like to see you all in our in-person hands-on training that we are having it very soon in Delhi and Mumbai. Okay. I hope you got something out of today's lecture. Okay. I appreciate your time and your patience on a Sunday evening. Multifidus is different, sir. Multifidus is a different ball game. Even you're sitting and signing on a piece of paper, we do cover multifidus in our lumbar spine course. So I want you to either access our lumbar spine course online, or you're welcome to come to Delhi and Mumbai, where I can explain about the multifidus in detail. Okay. I can wait here for some more questions. Again, thank you all for your time, energy to learn and help your patients and your athletes. If a patient has a knee and a hip problem, it is difficult to do complete knee flexion. Well, you might have to work on the mobilization first. Then you might have to perform the hip or the knee mobilization. If not, then you can try performing that in prone position, or you can simply tell them to perform a glute or a butt squeeze. Okay, I totally agree with you that if the knee flexion is not available, then you can start doing them hip extension or a hip squeeze, or you can do it with a TheraBand exercise as well. All right. Well, the resources and the books that I would recommend is only the research. Please follow the research and the evidence. You're welcome to join our cohort manual therapy program as well, which will be joining. It's a 1-year manual therapy dry needling practitioner program. Okay. You're welcome to join that. It is there on the website. Please go and check for the quiz link. You're welcome. And I would definitely like to see you all in Delhi and Mumbai hands-on training. If you have any more questions, I can stay here for 2 more minutes. Those are great questions, guys. You guys are doing great. If there are no more questions, guys, understand this was just an introductory course. This was not a detailed course on running injury. I can cover that much in my next. I've already taken 90 minutes. So thank you so much. I will definitely make plans to Chennai and Bangalore and other areas for sure. All right. So thank you so much, guys, for your time and energy. I welcome you all to join our Delhi and Mumbai hands-on training or our cohort manual therapy program, which is starting very soon. It's a 1-year certified or a diplomat manual therapy program. I wish all the best to you. Please treat and assess your patient in an evidence-based and a holistic way, and do a good ethical job and help your society. And please let us know if we can help you in any way to help your patients further. All right. I'm Dr. Parijat Kumar. I'm a certified spine and sports specialist from the US. And good luck to you all, and have a blessed day and good night.